الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleague, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific session, and I would like to welcome you in the IMC Family Medicine Club. We are happy and thrilled to have the 39th episode of the IMC Family Medicine Club that we have started 4 years ago. And with your contributions and presence and interactions, we will keep on going all the way every month, inshallah, to offer you the best possible scientific session that will enrich your knowledge and give you the opportunity to exchange experience with all the colleagues who are attending with us here today. So today, ladies and gentlemen, our topic is very unique and it's very important. It's something related to vaccines. But before I start, I would like to pave the way and set up the stage by saying that vaccination is a powerful tool to curb the disease or the infectious disease. And the change in the profile of our population, the kingdom, in the past couple of decades, mandated that we have to look into our populations with a different profile and different perspective. So we are getting our populations in getting older. So having an elderly populations in our community will also drive the age-related decline in immunity. Not only this, but also the high prevalence of chronic disease in our populations will add on top of the aging another comorbidities that will enhance the susceptibility of these population to infectious disease. And knowing that the natural immunity, which usually we get it after getting the disease, doesn't last longer. So that's why the only tool is to have vaccines that will give us another boost to face the infectious disease with a full immunity. And of course, that's why our role as a primary care physicians and healthcare provider is to screen those people at risk in our populations and also to diagnose and treat. But before that, we have to remember to vaccinate the susceptible people. So health promotion, early detections, and specific protection is the name of the game that will lead to the full protections of our community. So, of course, we have been so much engaged in the past 3 years in a campaign that was directed towards our public and populations in terms of the herpes zoster infection. And you have witnessed the great success in this campaign that have made the change in the mindset of our people in the community, and they started participating actively to come all the way and to seek for the vaccines and to protect themselves and their beloved one. But there is another component to tackle the problem is how to educate ourselves, to be accountable and responsible and have the wealth of information to identify our exact role in curbing the epidemics and to tackle the disease in our community. For this, ladies and gentlemen, I would like to tell you that we have been privileged here today to have two guest speakers who are well known in the medical community, and they have been selected meticulously to add a value to our gathering today. So we have Dr. Muhammad Samanoudi. He's an assistant professor on Al-Qura University in Mecca, Saudi Arabia, and he's a consultant of medicine, infectious disease, and transplantation infectious disease at King Fahd Armed Forces Hospital in Jeddah. And we have also Dr. Salim Barabia. He's a consultant in family medicine, ex-IMC, International Medical Center, and now he's building the family medicine department in the new launched hospital, which is a Salama Hospital. So I'm sure that you will add a real value to establish a new brand of family medicine. So we will start by Dr. Salim Barabia. He's going to talk about the herpes zoster vaccination in adults, and this will be followed by Dr. Muhammad Samanoudi. So please be ready with your questions to be given to our speaker at the end of the session. And I would like to ask our colleagues who are attending with us online to put their question in the Q&A box, so we'll be able to give it to the speakers as we come to the stage of the Q&A. So without any further ado, I would like on your behalf, ladies and gentlemen, Welcome, Dr. Salim Barabia.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank you for attending this session and to thank the Regulatory Committee for the Family Medicine Club and the GSK as well for giving me the chance to talk about our topic today, which is the herpes zoster vaccine. Today we'll talk about the structure and the function of the vaccine and how it was the study and how to implement the vaccine and how to give the vaccine. Inshallah, I would be helpful in to understand and to practice more giving the vaccine to the patient. Yes. ليش ما بينت هنا؟ We'll talk about the efficacy and the safety of the Shingrix vaccine, but first of all, we'd like to talk about the component of the vaccine. What is it containing, the substitute of the vaccine? It has to be on slides. خلي الدكتور محمد زعلان. Yes, خلاص we restart now. The vaccine, which is called the Shingrix vaccine for the varicella zoster infection, is composed of two parts. The antigen glycoprotein vaccine, the antigen glycoprotein, it's part of the vaccine, it's called glycoprotein. Part of the virus, part of the virus is called glycoprotein. Combined with what we call is the adjuvant system, which is improving, the immunity, which give more immunity and last longing for the life. So this is what we call is the glycoprotein here, and this is the adjuvant, which is combined with the antigen, which gives more immunity with the system in the body. It's a component of three parts, the MPL, the QS21, and the ribosomes. These are combined both together. So it's called the recombinant subunit. It's non-live vaccine, it's not killed vaccine. It's a recombinant protein. It's a recombinant subunit of the vaccine. We studied the efficacy and safety. This is what we call is the glycoprotein. It's available on the surface of the antigen. And this is the most important part in the development of the humoral and cellular immunity in the body. It's the glycoprotein. And this is the adjuvant system, and was component of three things. But you see now here there's a vaccine with non-adjuvant formulation. I mean, there is no adjuvant immune system, and this is with the adjuvant formulation. See, the immunity is very potent and lasts longer. And without adjuvant system in the vaccine, it's very short duration and decline with the age. So with the adjuvant part of the vaccine, the immunity lasts longer than without adjuvant. So our vaccine, Shingrix, is adjuvant system. Now we study the vaccine in the two studies. It's called the Shingrix study, ZEU. They have selected around 30,000 patients in the world, in the 18 countries, age 50 plus and 70 plus. They put it in two groups. So it was 50 plus and 70 plus. A study design was randomized, and the subjects were around 30,000, studied in 18 countries around the world. And they followed up in two phases. First phase was for 4 years. After 4 years, they have conducted the result, and it was in the age group of 50, was giving 97% protection against the herpes zoster infection and its complication. Like this, yani, from 50 and above, 50 to 60, 60 to 70, more than 70. And this is people of the population, all are more than 70 years of age, and it was giving 91 around. 91 protection against the infection and its complication for around 4 years. This is the first part of the study. Then the second part of the study, after the first 4 years, there was a gap for 2 years around, maybe time of Corona. However, they conducted another study for the same population. They selected around 7,000 in 18 countries. It's called long-time follow-up study. They conducted both over 50 and 70 years. And it was conducted for until year 10. So it was first study from 1 to 4 years, second study from the 6 to the year 10. So until the year 10, the efficacy against shingles and its complication was around 89%. So a 10-year-long protection against shingles can be achieved by administering Shingrix. So until year 10, from the first dose and second dose, it was the protection for 89%. And this showed the categorical benefit of the vaccine in the subpopulation like diabetics, dyslipidemia, hypertension, coronary heart disease, and asthma. All give a protection of around 91%. So if you have diabetics, you give him the Shingrix, he has a chance of 91% of protection against the shingles and its complication. Now, this is the, again, ما هو نفس الشريحة يا شباب الله. Yeah, this is when diabetic patient receive the Shingrix, which is a recombinant substrate, the protection will be 91%. But this is life attenuated vaccine of the herpes. The protection rate is 50% around. So a huge difference, almost double with the Shingrix vaccine, because it has what we call is the substrate unit, not a life attenuated vaccine. And this will has its own application when we give the prescription. Yani what kind of patient we can give it very safely and very competently. Now this is almost the same slide. Yani how it shows the efficacy in the patient on the categories of hypertension, dyslipidemia, coronary heart disease. All have very high rate of protection. Yani 97, 91, 91. لا معلش. This is the side effect of the vaccine. It's, pain is the most side effect, was in 86%, 68%. The good news is that it's very short duration of not more than 2 days. And it is, there is, however, no serious side effect with the vaccine for the whole years of the study. So it's giving pain in 68%, redness, swelling. This is in relation to the placebo. So you can give it very safe. It's considered very safe vaccination. Now we can administer the vaccine with the influenza, with the pneumococcal, with the diphtheria, tetanus, pertussis. There is no contraindication to give both together. And this is the guidelines recommendation. This is Saudi recommendation, 2 doses, 2 to 6 months apart for adult age 50 and above 18 years of age if they have considered any risk factor like renal failure or things like that. For the general population, it's recommended in the United States, in the Europe and Australia for the general population above 50 years of age. And for the current guidelines and recommendation for Shingrix in common comorbidities, it's recommended for diabetic, for cardiovascular, for asthmatic, and for chronic obstructive pulmonary disease. You can give without any hesitancy, you can give it very competent. Again, for the autoimmune disease, for rheumatoid arthritis, SLE, inflammatory bowel disease, psoriatic arthritis, multiple sclerosis, rheumatic and musculoskeletal disease, you can give. Current guideline as well recommend for the cancer patient, solid organ, renal transplant, human immune deficiency virus, and multiple myeloma. So we have a lot of categories we can administer the vaccine to the patient and help them with the safe life. This is the most important slide I really consider. It is your participation as a healthcare provider and family medicine and internal medicine, anyone who's discussing or counseling the patient about the vaccine. It will increase the rate up to 3 times. I mean, if the patient himself, he will come only get a chance of 25% to get the vaccine. But any guest counseling from the physician, from the nurse about the vaccine, even 1 minute, it will increase the rate up to 75%. We have to talk about it to the patient. We have to counsel a bit about the patient. The patient, they have concern about the side effect, about the, especially what they have with the coronavirus infection that days and the vaccine. I think we have to consider this opportunity. Any patient we can see, we can just counsel him about getting the vaccine. And that's it. Thank you for your...
Thank you, Dr. Salim. And now we'll move to the second part of our scientific session. This is going to be regarding the herpes zoster management update. And this will be delivered by Dr. Mohammed Samanoudi, who is Assistant Professor at Al Qura University and a consultant of medicine and infectious disease and transplantation infectious disease at King Fahd Armed Forces Hospitals in Jeddah. Dr. Mohammed has been with us for quite a long time, always supporting our sessions with his unique, updated information and a skillful way of putting guidelines into the real world evidence and bridging the gap by adding his experience on top of it. So we are very pleased to have you, Dr. Mohammed, and I would like to leave the floor for you.
Assalamu alaikum. First of all, I would like to thank the IMC Family Medicine Department and JSK and the Saudi Society of Family Medicine and the organizing committee for this nice meeting. And hopefully you will enjoy the time with my presentation today. So first of all, I was just promoted 2 weeks ago to Associate Professor, so we need to change it. So we're going to talk about the herpes zoster management. So in the beginning, before talking about the management, so let me walk you through the herpes zoster infection first. And at the end, we will reach to the management and the prevention in brief. Yes. Okay, so first we talk about the epidemiology. So in the United States, the herpes zoster occurs like in about 1 million individuals every year, and the CDC estimates approximately okay, but it's not here. It's not linked. Okay. Okay, so we say CDC's estimate approximately 30% of people in the United States experience herpes zoster during their lifetime, and the incidence rate is progressively increasing with the age and declined if we develop the varicella zoster cell-mediated immunity. So this is a figure just to show us how the herpes zoster and the post-herpetic neuralgia is affected by age. So whenever we're going and increasing the age, the number of cases with herpes zoster and the complication of it, which is the most commonly post-herpetic neuralgia, are increasing. So anytime we go like higher in the age, the complication and the incidence of herpes zoster are getting bigger. Okay, risk factors. So usually primary infection happens usually in the kids, and we call it the chicken pox. But what will happen? This chicken pox will never die, and we will have this varicella zoster virus becomes latent in our bodies and usually in the dorsal column. And once our immune system just goes down, the virus starts to reactivate. So in adults, zoster infection or varicella zoster or shingles are a reactivation, not primary infection. And usually happens after age of 50, and we will talk about that because this is the aging process. We call it immunosenescence. We are going to talk in details about that. Immunocompromised patients such as HIV, transplantation recipients, and patients on chemotherapy, immunotherapy now. We have a multiple immunotherapy for cancer patients, for multiple sclerosis, for inflammatory bowel disease. Now we are in the immunomodulatory medication era, and a lot of people, they are using it in different fields: dermatology, GI, rheumatology, any kind of subspecialty. We are seeing immunomodulatory medications that may put these patients at risk for herpes zoster infection. Okay, generally speaking, age-specific rates of herpes zoster are greater in women, even when controlling for age. And the incidence of herpes zoster is significantly lower in Black Americans compared to white Americans. So let's talk about immunology and let's go back to the basic years and try to remind ourselves about what is happening above age of 50. So usually if we are get exposed to infection, we call it the antigen. So our immune system, the first line of defense, most commonly is macrophage and dendritic cell, will engulf the antigen, or will engulf the herpes zoster virus. And the phagocytosis process starts to happen inside the macrophage. But the macrophage will ask for help, because phagocytosis of the macrophage itself is not enough to kill the infection. So the macrophage will do the antigen-presenting cells, will try to take a piece of this herpes zoster and just put it at the surface of the macrophage to try to ask for help. So the first responder to that help is T helper 1, CD4, T helper 1. So the T helper 1 now start releasing cytokines. The cytokines, some of them will go on the surface of the macrophage to stabilize it. And the other will go to activate T cell immunity and B cell immunity. T cell immunity, which is cytotoxic CD8, and B cell immunity, which is responsible about the antibodies, and they will help for killing this infection. And at the end, they will form T cell immunity, memory T cell immunity, and B cell memory immunity. So this is, we call it adaptive immunity. So innate macrophage, then T cell, B cell, we call it the adaptive. So all of these, this is just like to the figure explaining what we already mentioned a few seconds ago. And all of these, from the innate immunity, from the engulfing, from the phagocytosis, then antigen presenting cells, then asking T helper 1 for the help, then releasing the cytokines. The cytokines will stabilize the macrophage, and the cytokines will activate T helper 2 and will activate the B cell. All of these, they are gonna be affected after age of 50. That's why we call it immunosenescence, and those people at risk to get infection because at this time we call that their immune system is weak. And they are at risk for reactivation of the varicella zoster virus in our bodies. Transmission, so people with herpes zoster can transmit the varicella zoster virus to varicella naive person that they don't have it, and then it may develop as a chicken pox. Then after that it will reactivate. Direct contact to the active herpes zoster, so usually airborne transmission, we call it airborne if there is more than one dermatomes. So usually it's one dermatome, we just do a contact isolation. But if more than one, like 2 and more, we need to put those patients on airborne isolation and contact. So you need N95 and gown and a gloves and negative pressure room, because those people, they can transmit the infection by airborne. So clinical manifestation, localized or disseminated rash, systemic symptoms such as headache, fever, malaise, fatigue can occur. A group of vesicles or bullae are predominant the manifestation of this infection. But some atypical presentation people, they can come only with the burning pain, the neuritis, because we are going to talk in the like 3 to 4 days, rash become pustular, and acute neuritis, burning pain with the rash. But I saw many people, they come just with the neuritis, without the rash. And some of them, the rash will develop later. And some of them, they don't develop rash. It's just dermatomic acute neuritis. And we call this atypical presentation of shingles or varicella zoster. And those people, like I remember during my fellowship, we were doing a nasal PCR for those people, because sometimes we see it in the mucous membranes. But here now, we just like if any dermatomal with neuritis-like picture, acute, we treat them as varicella zoster, or herpes zoster, sorry, and they got better after the treatment. Complications, so post-herpetic neuralgia, frequently defined significant pain and persisting for 90 days after the onset of the rash. 10 to 15% of patients with herpes zoster will develop post-herpetic neuralgia, but people above age of 60, about 50% they develop post-herpetic neuralgia. To me, like in my clinic or in the hospital, actually every patient I'm seeing it with post-herpetic neuralgia. So you would say, like, do you think this is underestimated? I don't say that, but maybe in our community, or maybe we need further studies or further updated studies, because nowadays we are seeing the post-herpetic neuralgia a lot. And it's very, very annoying, very painful. The patients will, like, some people, they just like crying. They come to our clinic crying from the pain. Herpes zoster ophthalmicus, potentially sight-threatening conditions involving the ophthalmic division of the fifth cranial nerve. Approximately 50% have direct ocular involvement. So those kind of patients, if they develop the herpes zoster ophthalmicus, need to be seen by ophthalmologist. Once you start the medication, and right away need to be seen by ophthalmologist, because they may need intraocular antiviral therapy. And with the onset of the rash and hyperemic conjunctivitis, uveitis, episcleritis, and keratitis may occur and can lead to acute retinal necrosis. I remember I saw a couple of patients, and acute retinal necrosis is a sight-threatening for sure. those people, they may lose their vision forever if we did not pick it very quick and treated them appropriately. So this is just like an examples about the herpes zoster ophthalmicus. This is we called Hutchinson sign. This is when it comes, that's mean this is the beginning of the herpes zoster ophthalmicus. Once you see it, that means a couple of days you will see the herpes zoster ophthalmicus. It's very sensitive to herpes zoster ophthalmicus. It's just like a rash or this vesicles on the tip of the nose. Neurologic complication, aseptic meningitis, encephalitis. It's the second most common cause of infectious encephalitis after herpes simplex type 1. So it's the second. So it's very important. We need to eradicate it as much as we can. Transverse myelitis, Guillain-Barré. Actually, the three top organisms that can cause Guillain-Barré, the Campylobacter, the influenza, varicella zoster. Those top three that may lead to Guillain-Barré syndrome. Stroke syndrome, that's very important. Varicella zoster, can cause cerebral angiitis, a vasculitis of the cerebral vessels, and it can take up to 1 year. So those people after varicella zoster infection, after zoster infection, they may develop stroke within 1 year after their exposure. And nowadays, American Heart Association confirmed it that recombinant zoster vaccine decreases the incidence of stroke. It's clearly mentioned in the guidelines. Visceral organ involvement in immunocompromised, we see it a lot in our transplant population or HIV. They may come with a pneumonitis, they may come with a hepatitis, and they may come with encephalitis and CNS involvement. So diagnosis, usually in immunocompetent people, usually clinical judgment or clinical diagnosis. We just look at it, dermatomal, vesicular, pustular, with burning pain, neuritis-like picture. This is varicella, this is zoster infection or shingles. But in immunocompromised patients, sometimes we have atypical presentation, usually in immunocompromised patient complications, and most of the time we need to use a PCR, either a swab or a body fluid PCR. And majority we use it in the CSF. We send the CSF for PCR for varicella zoster, and nowadays we call it CSF meningitis multiplex. It's a list of organisms. You can just like put a couple of drops of that CSF in that kit, and it will tell you which one is positive. And that kit, it contains varicella zoster antigen, and if it matches, so this is a varicella zoster encephalitis. Management. So what is the goal of the management? It will decrease the severity and duration of the pain. That's very important. It promotes a rapid healing. So, doctor, you said this is a one dermatome and this is a viral infection and it will go by itself, so why I need to take the antiviral? Because of these. These are the benefits of the antiviral. Rapid healing, decrease the severity and the duration of the pain, prevent new lesions from coming, decrease viral shedding, and decrease post-herpetic neuralgia, and even decrease the duration. So post-herpetic neuralgia, it may take 3 months. With the medication, it will take less than that. So for uncomplicated herpes zoster infection, we use one of the following. The valacyclovir, we usually use 1,000 milligram 3 times a day for 7 days. So in our pharmacies, we don't have the bill with the 1,000 milligram, we have a 500. So we have to tell the patient to take 2 every 8 hours for 7 days. Famciclovir, we do have it, but not very common. And acyclovir, look at the acyclovir, is like 5 times daily. Compliance, honestly, 0. Who will take 5 times daily? I'm sorry to say that, but yes, let's talk logic. Like we tell the patient to take it 5 times a day, he will not take it, or she will not take it. So usually, I give the valacyclovir. Every 8 hours is doable. And the patient is convinced to take it, okay? For the complicated herpes zoster like immunocompromised, we usually start with the IV medications like high dose, 10 milligram per kilogram every 8 hours until the lesion. So we have 2 opinions here. Some of them, they said until the lesion are crusted. And some of the guidelines, they said 14 days are enough. So you can go with either or, but I think once the lesions are crusted, the virus is not active anymore. And the patient is not infectious anymore. And that's usually when they come to me, they ask like, can I kiss now my kid? Can I touch people? Can I sit with people? I tell them once the lesion is crusted, you are allowed for that. So once I see them in the clinic, lesion crusted, that's it. Even if I decided, I told them like, I gave them 14 days treatment, 7 days, I would tell them no need. That's it. CNS disease, it's very common. We see it in the hospital, and we usually need to give a very high dose of IV cyclovir, 10 milligram per kilogram every 8 hours for 14 days, and we usually need to watch for crystal-induced nephropathy, so we need to keep eye on the creatinine level, and we need to gently hydrate those patients because they are at risk to develop crystal-induced renal injury. Acute tetanus necrosis, similar to the CNS, we need to treat this acute tetanus necrosis, similar to encephalitis or CNS disease, with 10 milligram per kilogram every 8 hours, but it needs to follow by 6 weeks suppressive valacyclovir. 6 weeks suppressive to avoid any kind of reactivation because it is a very serious infection and a site-threatening condition. Post-herpetic neuralgia, I noticed like so it was mentioned clearly, you can use any one of those, but we noticed like gabapentin is one of the most potent medication can be used for post-herpetic neuralgia. Unfortunately now it's a controlled substance, so it needs to be prescribed. Majority of the times now you will not find it in a polyclinic, you will find it in a hospital. And people, they need to be seen like by a neurologist or anyone allowed to prescribe a controlled substance to give the gabapentin. Pregabalin, طبعا يعني from a long time ago it was like a controlled substance. And amitriptyline and duloxetine, they are not a controlled substance and also can help to treat a post-herpetic neuralgia. Usually, in my clinic, I like to use duloxetine, Cymbalta, Modexa, to use it like to start with 30 milligram, then I can increase it to 60 later on, and many people, they do good with that. Recombinant zoster vaccine currently is the preferred vaccine against the zoster, recommended in immunocompetent above the age of 50 and immunocompromised 80 and more, and available in Saudi Arabia in primary care center and in the private healthcare. Unfortunately, I think it's still not covered by the insurance for all people, but hopefully what we would got promised that it's going to be under insurance very soon. Why you should get immunized? To reduce the risk of developing herpes zoster, reduce the risk of the most common complication of the zoster, which is post-herpetic neuralgia. Even if, God forbid, if it happened and you got the zoster infection, the risk of developing the most annoying complication, which is post-herpetic neuralgia, it's decreasing. And lastly, it reduces the risk of varicella zoster complications such as encephalitis and vasculitis, especially immunocompromised patients. And we have already talked about the relationship between the zoster and the stroke and how is the vaccine helping to prevent that. And it was mentioned clearly in American Heart Association and their guidelines, the most updated one. And by here, I'd like to thank everyone. Thank you.
Okay, thank you so much, Dr. Muhammad, for this illustrative presentation that you shed light on the infection of herpes zoster and the way to manage it through different modalities of treatment and treating the post-herpetic neuralgia. So I would like to invite the two speakers to be here on the stage so we can receive the questions. And before that, I would like to ask the attendees to raise their hands if they have any questions. We have two questions here. نبدأ باليمين. أبو فارس.
Assalamu alaikum. Dr. Saeed Afif, family medicine consultant and IMC. Thank you, Dr. Muhammad. Thank you, Dr. Salim. I have two questions to Dr. Muhammad. Speaking about immune diseases, is there a way of delaying any strategies or measures that someone can delay the immune response above 50 years of age? The second question, do you have to diagnose patients of atypical herpes zoster if there's no specific symptoms, skin rash? Do you go for diagnosis by the nasal PCR or something?
Yes, so regarding the immunosenescence, actually, if you notice now, a lot of people regarding there is no way to make it later or try to delay it, but we are doing some strategies now to try to boost our immune system. If you notice, influenza vaccine, what people they are doing a lot of studies about? Doubling the dose. If we are talking about hepatitis B vaccine, what people they are doing with the elderly people? They are doubling the dose. So what we are doing, we are trying to try to find any way to boost the immune system, because even with the vaccination, sometimes we have a weak immune response because of the immunosenescence. So up to now, no, but we are trying to find some ways to boost our immune system. I think even in the varicella zoster vaccine or the recombinant vaccine, we are using this mechanism to boost our immune system, try to find any way to increase the immunological response to the vaccine.
Yeah, go ahead.
Regarding the way of the, yes, so this is one of the other features. Try to find the nearest mucosal membrane to try to swap it and to get it, but the majority you will find it in the nasal. So we were doing it, but I think it's limited here. But if you have it in the hospital, yes, it's something. It's good to utilize it, and majority of the time, if it turns to be zoster, it will come positive.
Dr. Muhammad,
Yes.
when we talk about the real world practice, there is some recommendation by some doctors to boost the immunity. They give zinc, vitamin D, and they give vitamin C as well. Not only by patient, but also by physicians.
That's
so
correct.
is it an evidence-based?
والله يعني the vitamin C specifically, some of the studies showed that effects, but the others like zinc, vitamin D, the evidence is there, but is not that strong. And in the guidelines, they are all of what we have mentioned, zinc, vitamin C, vitamin D is not there. And they are not recommending them to be used as evidence. Even with the COVID era, we were using zinc, we were using a lot of medications, nonsense medications, and at the end, they said no, none of them is helpful. So as in the guidelines, infectious-wise, no.
Okay. Dr. Salim, in your clinical practice, how do you tackle vaccine hesitancy when there is somebody who is eligible to have the vaccine as a high-risk populations and they are rejecting to have it? So what is your model of consulting these people?
I guess discussion and counseling about the effect and if he has seen somebody infected with the shingles or al-hizam al-nari and what he hear about it. Many people, or many patients in the clinic, they have heard about the shingles. They have maybe seen somebody who suffered it, and really, almost all of them, they have an idea about it. But if you encourage them a little bit, give them protection, give them the rate, the study, length of study, it's not 1 or 2 years, 10 years. I think most of them, they will take little rejection rate, not very high, really.
Okay.
So just discussion and education, it would be great,
Okay, perfect. What I usually do in my clinic, just to convince those people to have the vaccine. At the end of the consultation, I said, we did very well today and we have achieved the A1C. And now I'm going to refer you for the annual eye checkups, and I'll refer you to the dietitians to have a proper diet, and I will give you the vaccine for herpes zoster, and then I would like you to follow up with me after 3 months. So I integrate that particular piece of information as
In between.
in between, and it will be a solid statement that should not be subjected for any kind of negotiation. So it's a plan of management. So many of them, they anticipate that this could be the way to go to secure the state of art of managing diabetes or other chronic disease, and they will take it this way. So I think
VIP patient, I see regular patients.
no, Allah يعطيك العافية. No, it comes by experience. When we go through the experience in our practice, we develop our own way of managing patients.
Sometimes you can give a story. You
Of
can give
course.
a story. I have a couples, I advised them about the vaccine. The husband agreed, the wife, she did not agree. Later on, she got the infection, the wife. You see.
Yes. Yeah.
And هو كان فرحان فيه. مسكين.
Dr. Hashim, you have a question here.
Actually, I
please.
have 2 questions. How long the immunity lasts?
For the vaccine?
Yes.
It's long life, almost. We have explained the study. It has 2 parts. They have studied the vaccine at year 4, and it was the protection rate 97. And they continued the study until year 10, and the protection rate was 91%. So it is almost only 2 doses. There is no indication to give a booster. صح يا محمد?
But they
It's
said
only
it,
2.
only, it lasts only for 10 years. Then after 10 years, there is any booster?
No, the study now is until year 11. The study now is until year 11. Maybe in the coming years they give a study or something. However, it's only 2 doses. It will last lifelong until now.
It will last only for 10 years.
No, the study is 10 years. The study is 10 years. But until now, there is no recommendation to give after the 2 doses. It's only 2 doses, 2 to 6 months apart. At year 10, it would be the protection is 91%.
And there is any booster?
Until now, no.
Yeah, let's take the benefit of the first 10 years. And
يا هلا من يعيش.
all right. Dr. Salim, what if the patient missed the second dose more than 6 months? Usually we recommend a second dose between 2 and 6 months. So what is the modality in
You
this?
see, he got the second dose. There is no indication to repeat the 2 doses. Just he got the second dose, and that's it. But the full protection, upon the study, 2 doses, 2 to 6 months apart.
Okay, very good. Dr. Abu Nawas?
Thank you very much. I think this is, since we are in the viral era, I'm just wondering regarding the post-herpetic stroke, comparing with the cardiovascular insult. I just wonder what kind of pathology is recovering, because in 1 year, we give a person for cardiovascular insult to be recovered regarding what's in the brain. What about the viral effect in this case?
So some studies now, they are studying the effect of getting varicella zoster infection with acute coronary syndrome, and some of them, but it was just a kind of retrospective, they are having some matching between cases of post-zoster infection and having new MIs, but still is not, strongly evident about that. But the one that is strongly evident is the stroke, and it's very well known right now. And we actually warn our patients, specifically if they develop varicella zoster encephalitis, that if any like time you develop like any weakness or symptoms of stroke, you need to come to the hospital right now because this is stroke till proven otherwise.
Okay, thank you. Any other questions from the audience here? Okay, we have two questions from online attendees. One is, why do we see more herpes zoster nowadays? Is it reporting getting better, or there is something to do with the post-COVID era of immune suppression?
So specifically in my clinic, I noticed like a lot of people, they develop zoster post-viral infection. Like if you talk to them, they say like, I got like a kind of flu 2 weeks ago. Then you do the CBC, you look at the absolute lymphocytic count, it's below 1,000. So the lymphocytic count is affected, and now the patients start to have reactivation of the varicella zoster. You talk to other people, they said like some report talking about the stress and the effect of stress on the immune system and the increase the cortisol level, then the immune system, it will go down and the herpes zoster will reactivate. But still not fully clear. But I think like the viral infection, the effect of viral infection, and the COVID specifically, because COVID is one of the most common viruses causing lymphopenia, and we are seeing a lot of cases of post-COVID zoster infection, a lot.
Absolutely. Dr. Mohammed, why the cutoff point of age is 50 for herpes zoster and 60 for RSV virus?
Yeah, so I think it's not. I think it's just a study-wise, but I don't.
Study.
Yes,
Yeah.
I don't have any clear answer for that.
right, okay.
But I have a question, Dr. Ashraf, like for the audience.
Yes.
What if you got a patient who has a negative antibodies against zoster, and now they are asking you, this patient is going for a transplant or immunomodulatory medications, can I give like recombinant zoster vaccine to give them immunity? So what do we think?
Yes. Any answer?
Exactly. So recombinant zoster vaccine will not give us a primary immunity against zoster. So those patients, they need to get the life attenuated vaccine first, then need to be boosted by the recombinant. That's the exact one. So I got a patient with multiple sclerosis going for immunomodulatory medications and 0 IgG for varicella zoster. Then they were asked like what to do. So recombinant with Shingrix, it will not give us a primary effect or a primary immunity against varicella zoster. Usually it boosts our own antibodies to get higher, but it will not give us a new antibodies. Yes. Remember the Zostavax or the child one? Yes, exactly. Before becoming immunocompromised, just let them form antibodies against the disease. Then after that, anytime later on, let them take the immunomodulatory medication, and anytime after that, you can give them the Shingrix or the recombinant vaccine.
Okay. Any other questions? Yeah, we have a question here. Mike, please.
Can I give a vaccine for people more than 8 years old?
8 years? 8 years?
8 years.
Or 80.
80.
It's 0. Yes.
Yes, of course, yes, you can give. Because they recruited in the study 70 years and above until year 10 of the study, and the protection rate was 89%. You can give, yes, of course.
Okay.
Yeah.
All right. I think this is all what we have here today as questions from the audience and from the online attendees. So, ladies and gentlemen,
السؤال كده لمحمد أنا عاد حسن. Now, if you want to give somebody who's less than 50 and he has a patient or parents get the infection and he want to get the vaccine, is less than 50. It's not indicated by their guidelines. However,
yes, actually, some like a kind of not a strong evidence, but To me in the clinic, I give it like out of
Out of
yes.
what they call it,
Out of label.
أيوة.
Yes. So I have like a couple of patients. She got zoster. She's a young,
Yeah,
not
right.
immunocompromised. She got zoster 3 times
Yes.
within 2 months.
Reacted.
Yes, I worked her up for everything. Her white blood cells is excellent. She doesn't have HIV. She's healthy, but she's very anxious. She's like anxiety with panic attacks and ألف على قول الدكتور. لكن what to do? This is third time. Then I just like counseled her about the vaccine. I'm like, this is the one that I will give the vaccine.
Shingrix.
Yes, I gave her the Shingrix and I never saw her after that.
ما شاء الله.
I hope inshallah.
يعني هذه good story يعني for the
Yes.
Shingrix.
I mean, like I never saw her like with the Shingrix after that. But this is the one that it's out of the guidelines. But you feel like this one she will benefit from because there is no, if we can give it above age of 19, to me, in my opinion, there is no any way. It's just like a way to try to keep these vaccines for the most needed people that they need this vaccine. But I think if we are giving it above age of 19, I think there is no problem if we give it to people that are in need in such situation. That's actually my theory behind giving
And
her.
this is expert opinion.
Yes.
جزاك الله خير.
Okay, I think we are coming to the end of our scientific event. On your behalf, I would like to thank our guest speaker, Dr. Muhammad Samanoudi and Dr. Salim Barabia for their wonderful contributions and enriching our scientific event with a lot of data and practical points. And I would like to extend our thanks to the Saudi Society for Family and Community Medicine, JSK for sponsoring this event, and the well-organized event by the ملتقى الخبرات لتنظيم المعارض والمؤتمرات. But before we leave, ladies and gentlemen, I would like to remind you and hold you responsible to identify those people at risk in our community in our day-to-day practice: elderly patients, patients above the age of 50, elderly patients with multiple comorbidities, patients who are immune compromised. They are the ones who have to have the vaccine. Vaccine is durable, safe, efficacious to give, as we have heard from Dr. Salim, a very good immunity that lasts for many, many years. And the first dose has to be taken, and the second dose has to be taken between 2 to 6 months. But we usually ask our patient to have it after 2 months, not to get missed within the big gap between 2 and 6. So make it clear that he should come or she should come within 2 months. With this way, we can protect our community, and we will be able to demonstrate our competency as a caring physicians and a gatekeeper of the healthcare system as a primary care physician and a nurses in a family medicine to do the best for our people, our patients, and our nation as well. With this, I would like to thank you, and I wish you a good day, and stay tuned for the 40th episode, which will be coming very soon next month, inshallah, for the IMC Family Medicine Club. With this, I would like to thank you, and have a good night. Thank you.
يحييكم العشاء.